Hello, friends. I hope this audio is going to be okay. This microphone is in a weird spot, so who knows if it will be or won't. Just looking at what you're looking at. What are you looking at? My dirty bathroom. Let me just get in the way of the products so they're not distracting. Okay, so this is my second effort to go live at the request of one very wise and astute subscriber who asked me to do a makeup tutorial. And I thought, well, yeah, sure. This will validate my existence as a beauty influencer. But no, really, I thought, let's just take some lives while I'm getting ready for work and I could show people what I'm doing there if they're interested in that. And we'll talk about whatever you want to talk about. And if not, I have topics set so that I can be prepared to properly monologue and entertain you, edutain you. I think this field is now called edutainment. So that'll be the plan. Last week, little amateur hiccups there. I had scheduled the live and then we had some refrigerator issues. And so, of course, the repairman showed up during the 30-minute window in which I was doing this. So I did not fully get to the part about talking about my eyeshadow, which is what I think this subscriber wanted to hear. So I may talk about that a little bit today. But if no one is on here, which I don't know how I can tell if anyone's watching this, but I don't see any chats yet. So if there are no message requests, then we will talk about vasopressors. Because I did a blog post about that. It's been a couple weeks now, but it has been something I've been talking about. And I talked about it quite a bit on TikTok. I've got a couple of TikToks on it. I think it's just it's a common thing. I also am recently starting a whole series on YouTube where I talk about frequently asked questions I get from NP students. And pressor selection is probably one of the top ones. So, all right, let me start. I just want to tell you, last week, I think I told y'all that I have rosacea. My skin is super duper dry. So you have to moisturize before you put the makeup on. And last week I was using this stuff, La Roche-Posay. I think that's how you say it, which I really like. But today, and I won't go through this with every product unless you particularly want to know. But I don't think that's why most of y'all are here. So, but I did want to share, this is another thing that I just adore. I buy this in bulk, Peter Thomas Roth, water drenched hyaluronic acid. And it's I don't know if you can see that. It's not a cream. It looks like it, but it's actually I don't know what you should classify this as. This is why I'm not a beauty influencer because I don't know the words. It's just super, super hydrating and it feels really good. It just soaks right into all those dry spots and makes things feel better. It's lovely. So I already put that on. And then I'm going to put my primer on, which I love. This is Bobbi Brown Face Base. Love it. Okay, so a little bit of background on the vasopressor thing. So actually, the question that I get from students is not usually what pressor do you choose. It doesn't start that way, at least. The way it starts is we go into a room, we see a very sick ICU patient who's got, tubes everywhere on the vent, lots and lots of drips, lots of things dinging on the monitor. And I think even if you've worked as an ICU nurse, it gets overwhelming because you can walk in the room and say, okay, this is a sick patient. But when I say, what's the plan? People kind of get really stumped. And I think it's because that transition from being a bedside nurse to being a nurse practitioner is having to put into words the medical terminology of the diagnosis. You have to start with what the diagnosis is in order to get to what your plan is. And so sometimes I think people have a hard time defining what the diagnosis is. And this is not just new providers, y'all. This is across the board. These are people who've been practicing for many, many years, from NPs, PAs to physicians. I also take a lot of calls for triaging patients from outside hospitals and other specialties within our hospital. And across the board, people struggle with this. Communicating what you're seeing, pattern recognition is there. You can look at a patient and go, this person's sick. But defining what exactly it is hard for people. So I say all this because the way it works is I'll go in the room with a student. I'll say, what's your plan? And they'll say, well, keep weaning the pressors, keep weaning the vent. Oh, okay, but we got to start with what's wrong with them. And so we'll back into, okay, what's a primary problem with this patient? And generally speaking, the ICU, shock is one of them. But I find that new NPs don't use the word shock. They'll just say hypotension. It's important because you have to get to what's causing the hypotension. So hypotension with signs of end organ damage is shock. So, but there are multiple types of shock. We all know this, right? There's obstructive, there's septic, there's hypovolemic, there's hemorrhagic, neurogenic. So there's a lot of different types of shock. And until you can really whittle it down to which type of shock it is, and sometimes it's multiple, you really shouldn't be choosing a pressor. So we'll be standing in this room. They will be able to appropriately identify that this patient has hypotension and they need pressors. And I'll say, okay, well, what kind of pressor are you going to put? And they'll say 90% of the time, Levofed. And I'll say, okay, why? And that's when we get stumped. That's when people go, because that's standard of care, or because that's what we always use, or because that's protocol, which isn't necessarily untrue. Most of the time, a lot of the time, Levofed is going to be our first choice. But it's really, really important in my mind to understand why it's your first choice. Because number one, you need to pick the best drug for your patient. And it starts with knowing what's wrong with your patient, understanding what the pressors do. Number two, you're going to have to be able to verbalize why you're doing things. You're not always going to be working in a practice where people are on board with what guidelines are and what first choice pressors are. You need to be able to explain to them what the drugs do and why you're choosing these drugs. You just do. This is good practice. So anyways, that's a little bit of my spiel on why it's important to understand the type of shock. It starts there. It starts with appropriately diagnosing the type of shock you have, because Levofed isn't always the best pressor. It's really not. There are more targeted pressors that you can use, and it's not always a pressor. Sometimes it's an inopressor. Sometimes it's a straight inotrope. Sometimes this is really weird, when a patient has heart failure and they've got volume overload and left-sided heart strain because of right-sided overload, an inodilator might be the right choice for them. So it's just, yeah, how else can I say that? Other than that, it's just good to appropriately diagnose what's wrong with your patient first. Okay, I have to get started on this, or else I won't be ready for working time. I'll just get on here and like talk, and then I won't actually be ready. So bear with me for just a second. I cannot tell if anybody's on here or not. I have no idea. But if you are, and you have things you want to talk about, this would be your window of opportunity to get some free advice or feedback. I have been kind of busy this week with some of my consults. If you're just stumbling upon this and you don't know me or know my stuff, I am an ICU nurse practitioner, and I work in a mixed ICU setting. So I take care of people who are in pretty much all types of ICUs, with the exception of trauma and some of the nitty-gritty neuro stuff. I do pretty much everything else. And so I like that. I get a little bit of balance of everything. And that's my full-time job. I'm currently working sort of split. I'm doing some days and some nights. And on the side, I have this little business where I mentor NPs, nurses and NPs, and I do interview strategy stuff. So it tends to be a lot of people who are, a lot of the mentorship requests I get are people who are looking to go back to school and want to make a good choice and are having a hard time deciding where to go to school or what specialty they want to go into. Or it's somebody who is practicing as an NP, but is maybe fairly new and has been in a really bad, toxic work situation, and they can't really see the writing on the wall, and they don't really know where to go from here. It's really just disheartening to see people go through that kind of stuff. And I started doing this because, when I went to work, I got it was really hard to get through rounds because I had so many questions from nurses who were looking to go back to school. But the more I started doing this mentoring thing, the more I realized that there are a lot of NPs out there who are not trained well, because I have a lot of bias and irritation towards most of our school systems. I think they do a crappy job preparing us. And so it kind of hurts our reputation. So I think there are some people, I know there are a lot of people who are working in environments where things are very unhealthy. And, they just need a third party. They just need an objective person to look at it and go, here's what I think you should do. And that brings me a lot of joy. And the last thing I do is interview stuff. So when I got 5 job offers when I was an MNP, and I went to 2 formal interviews, and I knew that I was going to have to do a little bit more preparation. I mean, I was a job hopper as a nurse. I had, I don't even know, 6 or 7 jobs as a nurse. And I went to a bunch more interviews than that. And the interview was always like, hey, what's your work experience? When can you start? Can you tour the unit? I mean, that was basically the gist of it, you know? And so I knew that it was going to be a lot more competitive in the NP world. I knew that there were other people that were interviewing. And oh gosh, see, doing this when you're doing something else and distracted. For those who are going to be working with me tonight and seeing me, don't judge, okay? Don't judge. At least it'll be nights and it'll be dark. You won't be able to tell. Where was I going with that? I lost my train of thought. Oh, so I knew that there were other people interviewing, and I knew that I needed to like up my game. I knew it was going to be a little bit more of like a professional kind of thing, especially like for the second job I interviewed for, which was like a 6-hour interview. And I was like, oh my God, what am I going to say? So my husband is not in healthcare at all. He is in the business, like private sector, and he knows a lot about leadership, and he interviews a lot of people. He hires and fires a lot. So anyways, he was like, you got to read this book. So he gave me this book. I read it. It was life-changing, literally life-changing. I read it and I was like, why in the world are we not taught this as nurses? Like, why are the practical things not taught in school? You're taught how to be a nurse. You're taught how to be an NP. You are not taught how to find a job. You are not taught how to interview for a job. You're not taught how to negotiate. You're not taught any of the like real world application stuff. I find it like such a huge disservice. Did I already do? Yeah, I already did blush. So anyways, after I did that and I really rocked 2 interviews and like, just like was mind blown at the fact that there is a way to study for it and do it. I was like, why aren't we doing this? So I started helping people do it just kind of like on the side. And then after I started the social media platform thing, I started teaching people. So I teach through like a digital course that I have, and I do mock interviews. And I like that almost more than anything else I do, because it is so rewarding for people who come in like they're super nervous, or they've got a lot of pressure on them to get this one particular job. And we do a mock interview, and I would say most all the time I have advice I can give them, and then they get the job. And like just the overwhelming excitement of, especially if you've been waiting for a long time to get a job, and then you finally get an offer. So anyway, so that's a little bit of me and about what I do. And on my website, I write a blog. So I do a lot of clinical like teaching and talking on TikTok, because it's easier to just break things down into 3-minute sections than it is to do it on a full YouTube. And I do blog posts about clinical stuff on my website. So you can join the email list if you want to get those updates on those. Okay, so back to pressors. Yeah, because I don't see any messages. Just me out here, friends. Just me. I think I said this in the first one. If you didn't watch the live stream the first time, but like, I feel like to be the kind of person who's going to go on a live and do okay, you are a little bit like, not narcissistic, but like you're okay with the ego, right? In our household, my oldest daughter talks nonstop. And when she was little, she would play with her little figurines and they would talk to each other for like hours. I'm like, oh, she's in there monologuing again. And the running joke is that only the villains monologue. The good guys never monologue. So what does that make me? We're exposing all my flaws here. Okay, so pressors. All right, pressors. Start with, okay, before you even get to what type of shock you have, it's important to, oh gosh, this is the part where I'm supposed to be talking to, I think it was MC that asked for this, about what eyeshadow I'm putting where. So this might be fragmented, I apologize. Start with memorizing what the adrenergic receptors are, what the main ones that are involved in catecholamine response and ramping up the system and getting the blood pressure going. They work in different ways. So you memorize what the receptors are, and then you memorize which drugs hit which receptors, because these drugs all hit, for the most part, they all hit some degree, most of the receptors, but in different affinities. Like this one has a stronger affinity for this receptor, and this one has a stronger affinity for this receptor. And if you understand that there's more tendency to bind to a certain receptor, and that receptor, you understand the properties of what happens when that neurotransmitter is stimulating the cell to do a certain thing, you'll understand why certain side effects or effects occur more than others. That makes sense? Like a little hairy. So the main receptors that we're talking about when it comes to blood pressure is going to be your alpha 1. So your alpha 1 receptor site, these are in the vascular walls in the endothelium. So these are pipe squeezers. Drugs that bind to the alpha 1 receptor site create increased SVR by squeezing down on the pipes beyond the heart, right? So outside of the heart. So their effect is primarily squishing, right? Doesn't really have any direct effects on the heart. Not direct, but we'll get to why it has indirect effects on the heart in a minute. So your alpha 1 receptors. So there doesn't tend to be the what am I trying to say? Tachycardia. There doesn't tend to be proarrhythmic type stuff happening because it's not squeezing on the heart. It's not acting on the heart. It's just acting on the vessels. This is going to be your neosynephrine. So neosynephrine is a primary alpha 1 agent. So you are not, this is why it is usually the drug of choice by people who are transient effect, low blood pressure, that they don't want to put any extra pump on the heart. So people who are over sedated, so anesthesia, post anesthesia, transient stuff like peri-intubation, where you drop your blood pressure from sedation and it'll come back in a minute. You can make an argument for like just strict septic shock, but there's a reason why Levophed is probably better. We'll get to in just a minute. Yeah, so alpha 1. Okay, alpha 1 pipe squeezers. Okay, beta 1. Beta 1 is, think beta 1, one heart. These are going to be your pressors. These are really more, okay, these are going to be your drugs that have more effect on the heart. They're going to create more squeeze on the heart. These are the receptors that act on the heart. So it's going to increase your inotropy. It's going to increase your chronotropy. You're not going to have as much of the vasoconstriction effect with primary beta 1 effect. Now, remember what I said, most drugs have some affinity for all of them, just in greater amounts, right? So things that are primary alpha, like Neo, have very little beta effect. But things that are primary beta have very little alpha effect. Okay, so I got to refer to my notes so I can remember to hit all the things. We're not really going to go. Okay, so dopamine, Ang2, you know. So I think I'm just going to stick this conversation with just the primary ones, alpha and beta. Okay, let me do this for a second. Okay, so when I am doing my eyes, I try and kind of, let me see if this color is, yeah, I think I'm gonna do this color. So this is the color palette I'm gonna use today. This is Makeup Geek. I also like Urban Decay, which I just bought a bunch of new stuff of that's coming in Christmas time. And I don't always do the same colors every day, but I follow the same pattern, if you will. So I start by taking, this is Sigma E, oh God, I used to have this. It's worn off. All right, but it's basically like, I don't know what you call this, like a medium brush-ish. Let me see if you can see that. It's not super firm, but it'll allow you to apply some loose powder, but in a little bit more targeted place than like a big brush. So I take this, I get my medium range color, which today is going to be this one, So this is kind of medium. This will be my next dark, and that'll be my darkest, and probably one of those two will be my lightest. Okay, so I'm just gonna dab it a couple times, and then this is really bizarre. How many people in the world are interested in makeup and pressers? It's like a random grouping of things. Suppose that fits me very well. So I recently found out that I have ADD. My friends and family are tired of hearing me talk about it. It's like, good God, Brianna, it doesn't even matter. You've always been this way. We know. I think it was just like eye-opening for me. And so therefore, I talk about it a lot because I'm like, oh, not that it changes, it does change things because it like validates a lot of the things that I struggle with. So it makes me a little bit kinder to myself. So anyways, my point in that whole thing was I go off on tangents. You just have to go with them. Okay, so what I did was I just put it like all, oh God, legs going numb, all kind of on the upper part of this part of the eye. Oh God. Okay. Yeah, this is why I'm not a beauty influencer. Okay, so anyways, you put it up here, and I just go above the crease and I just kind of rub it in there. And then I'm done with that one. And then next, I'm going to take this like angled brush. This is a Sigma E70. It's like just an angled brush, basically. It's a little bit firmer than the last one. And I go with my mid-range color, which is going to be that one. That one. And then I just do like this windshield wiper thing. I go literally right in the crease, and it's going to go like a little bit above and a little bit below. That's okay. That's kind of what you're looking for. You're just looking to sort of like make this part recede, I guess, because dark makes things recede. And I do like 2 little taps, and then I just go back and forth, back and forth, back and forth. And that's it. Okay, that one got a little bit aggressive there, but that's okay. All right, so then I'm done with that one. And then I take this, which is I don't even know what this is. I got this, I think, at TJ Maxx. It's just like this little thicker angled. It's got a little bit more width to it, so I can put product and it'll stay right there. And I take my darkest color, I dab it twice. So I'm doing that one. And I go in the corner. And I just kind of like wedge it in there, just like a swan, which nobody ever has anymore these days. Swans are great tools for reading numbers, but they really don't change outcomes, so we don't do them on anybody anymore. But man, it is nice when you have those numbers because you feel like you know what's going on, right? You know what's going on. No guessing. Okay, and then I'm just going to kind of blur this a little bit with a loose brush. Then the last step is to take this little... I've had these brushes so long, I can't even tell what they are, what numbers they are, but this is another Sigma brush. It just looks like this. Okay, it's just a little like, it's kind of, I don't know how to describe it. I don't know the words because I don't live in this realm. And then I just take my lightest color and I put it on the inside, and drag it down a little. And I'll pull it in the inner corner of my eye too. I feel like this should definitely be its own niche. ICU and makeup. How many people would join that? Two people would join that. Thank you for joining us. Okay, and then I just kind of like blend it all out. Just blend it all out. Okay, so we're talking about pressors. We talked about alpha-1 receptors. So we're going to talk about beta-1 receptors, which are your pumpers. I call them the pumpers. These are the drugs that are going to have effects primarily on the heart. ICU. So when you're looking at your purist, like which drugs really only hit one particular receptor, you have neo, which is hitting your alpha, and you have ICU, which is hitting your beta. So people who are bradycardic, the primary issue is bradycardia with shock, ICU. That's kind of what I go to. I'm not a cardiologist. Cardiologists would probably tell you a little differently. I don't know, but this is how I practice, y'all. This is just my opinion. And then I start memorizing which of the other drugs that we call inopressors that have some inotropy effect and some pressor effect. Inotropy, pressor, this is how I think about it. And that would be your levofeds, your epinephrines, as the primary ones, right? So the difference between levo and epi is that they have a little stronger affinities for each of the receptors, right? So levofed has a little bit more alpha over beta, right? A little bit more alpha effect, a little bit less beta effect, but it's fairly balanced. It's pretty darn close. Epi has more beta than alpha, so you're gonna have a little more heart and a little bit less squeeze. So they're just a little bit of a yin and yang. This is how I think about them. The reason that levofed is our go-to quarterback default choice when you don't know what kind of shock you have is that you get effects on a little bit of everything, right? And with levofed, you're going to have less of the proarrhythmia, less of the squeeze on the heart if you don't know what degree of heart failure they have. So levofed tends to be the default for all types of shock, and that is why. Epinephrine is really better for folks that you know are cardiogenic shock. If I know they're cardiogenic shock and they're already on levofed, I'm going to put on some epi real quick, like going to try and get some pump on that heart if I know it's cardiogenic shock. Let me go back to neo for just a second. Neosynephrine, okay, it's primary alpha. It's going to squeeze the vessels beyond the heart. So think about it like this. If you have a sick heart, if you have ischemic heart failure, if you have cardiomyopathy, if you have a depressed EF, if you have a sick, ailing heart, and that heart is like struggling to squeeze and they're in shock, and you put them on neosynephrine without giving them any beta effect, you are making this poor sick heart work even harder because you took these pipes that were maybe okay or even possibly dilated and squeezed the crap out of them. So now this heart's having to squeeze even harder against these blocked pipes or these squeezed clamped down pipes. You're going to make a sick heart worse. You're probably going to make that person worse. So neosynephrine is not my choice for cardiogenic shock. Cardiogenic shock means an inotrope. Now, the question is, do they need a true inotrope like dobutamine or milrinone? Milrinone is a little bit different, PDE5 inhibitor. That is often the question, but the problem is in the ICU, it's not always one or the other. Sometimes it is. Sometimes you do get like an MI, pure cardiogenic shock, but a lot of the time it's like somebody who had heart failure who then got COVID or got septic, and now they have septic shock and cardiogenic shock, or they have hypovolemic shock and cardiogenic shock. So a straight inotrope isn't always the right answer. It just depends. You have to do assessment on these people. You have to do all of the things to work through what type of shock you think they have and what their current volume status is. And there are a lot of different ways to do that. I don't know how much of that I really want to get into in this because it could take forever. But not a lot of people have swans anymore. So a lot of times it is going to be your clinical assessment. I start by ruling out the types of shock. Are they hypovolemic? What's the story? Have they had diarrhea? Have they been vomiting? Do they have DKA? Is there something else going on where I suspect that they're dehydrated? And then I start doing clinical exam. Is the mucous membrane dry? Do they have skin tinting? Do they have pulse pressure variation on your arterial line? And then if I think they're dry, will they respond to a small bolus? So you could either give them like a 250 ml bolus and see what happens to that art line, or you could do a passive leg raise, which I do like to do. The problem with the passive leg raise is, okay, so this is like an auto infusion, right? This is like giving them, I think it's equivalent to like 200 mLs of saline. So you have them kind of sitting up, and then you flip them and you put the feet above the heart and you give it a couple minutes and you see what happens. But if the patient's awake, a lot of them have this Moro reflex where raising their legs in and of itself will raise their heart rate, which will increase their blood pressure. So you have to take it with a grain of salt for whether or not that's happening or whether or not it's truly a response to volume. So it's not always a pure solution. POCUS, you can always do a point of care ultrasound of the heart. If you can't even do that, you can look at the IJ and see, does it look plump? Is there respiratory variation? So when they take a deep breath in, is it flattening out like a pancake? You can look at the IVC. You can look at the hepatic vein. A lot of people do that. So there are different ways you can do it. There are devices you can use. I like to look at the art line and speed it up really fast and see if there's respiratory variation. I really, really love, there's a lot of these non-invasive continuous cardiac output devices out there, Cheetahs, FlowTrax. There's a new one that's come about. I think, is it Edwards that does it? That's like a finger, what's it called? Like ClearSight, I think. It's like a finger probe, so it's not even an invasive art line. All of these kind of estimate what your SVR is, what your stroke volume is, what your cardiac output is, and what your stroke volume variation is. And your stroke volume variation can tell you if this patient is dry, they would respond to a volume bolus. However, this cannot be a spontaneously breathing patient, so they have to be on the vent and not breathing and have a pretty decent tidal volume. So if you're on the vent, jack up the tidal volume to like 500 or more to get, because your whole point is you want to see with a large influx of air in the chest if the blood pressure drops. So are you doing this kind of number when there's a big push of air in? So jack up your tidal volume, make sure they're not spontaneously breathing, and they can't be an AFib. That invalidates it. So anyways, if that number's high, it means they might respond to fluids. So you can give them some fluids kind of more in an educated way than just guessing and saying, let's give this patient a liter bolus. Like, that's not the best way to do things anymore. Other things you can do. What are other things you can do? Okay, so then what type of shock? One of the first doctors I ever started training under had me, I think it was like maybe day 3 or 4 I was there. He had me go in a room with no information except what I saw in front of me and come back and tell him what type of shock the patient was in. And I was like, how do I do that? And so I did all my things and I came back out and he was like, well, what kind of shock is it? And so I was like, I think it could be this. I think it could be that. It could be this. And he was like, well, what did the patient feel like? I was like, I don't know what he felt like. He wanted me to define whether or not this patient was wet, dry, warm, or cold. So it goes back to that foundational, is this wet and cold shock? Is this, so cardiogenic shock can be dry, but we worry most about when they're wet and cold. They're not perfusing and they're wet. You're going to have to give them some vasodilator effect and open up the heart and diurese them, which may actually help with blood pressure. And put an inotrope on there probably. You're probably going to have to do both. Versus like your septic patient who's maybe going to be on the drier side and warm. The problem is, like I said, I would say probably 50% of the time, it's a little bit of everything. So how do you know? How do you know? Okay, this is the point where I got to go back in and cover up what little bit of eyeshadow came down here because I have the darkest circles in the world. So that's volume status. And then hemorrhagic, here's my spiel about hemorrhagic shock. And we're kind of veering off of vasopressors, but this is how it goes. This is how it goes with ADD. I honestly could care less what the H&H is in hemorrhagic shock. I could care less. To me, this is a clinical diagnosis. You go in a room and a patient has shock. Maybe it's new, maybe it's not, but they're putting on pressors, okay, because there's shock, because that's what people do. And they are vomiting blood. And it is frank blood, like frank red blood, even if there's not a heck of a lot of it. There's a basin and there's maybe, I don't know, 150, 200 mLs of blood in there, but it is frank red blood and they're in shock and they're pale. Who cares? Who cares what the hemoglobin is? It doesn't matter. That patient is bleeding. They're exsanguinating. Something is pumping. You need to give them blood. You need to give them blood, but that's only going to temporize things until you can fix the bleed. Fix the bleed. So one of my pet peeves in the entire world is when you're working night shift and you have a bleeder and you're begging and borrowing and pleading for someone to come in and scope this patient. And the answer is, well, just temporize them until I can get there. You know how many products of blood I'm going to give until this? Sometimes it spontaneously resolves. Sometimes it does. Anyways, my whole point in that was if it's hemorrhagic shock, if you need to do a pressor, whatever. But what they need is blood. They need blood. They need blood and they need resolution of the bleeding. And probably what they need is not a bunch of blood pressure, because the higher the blood pressure, the more they're going to bleed, right? So this is my pet peeve when people are like, well, is hemoglobin stable? So I don't think this shock is related to the bleeding. Yeah, it is. Yeah, it is. Give them blood, keep the blood pressure moderate, and fix the bleed. Like appropriately treat the type of shock you have. Okay, so that's hemorrhagic. We talked about cardiogenic a little bit. Septic. So septic, this is why Levophed is so good for septic. They have a lot of vasoplegia. They have a lot of vasodilatation with septic shock. So you give them fluid, but then it just leaks out into the tissue and they get edematous, right? Because 75% of it doesn't stay in the blood vessel. So give them some heart squeeze as well. Usually the heart is strained. So Levophed is great for this. We used Ange2 for a hot minute when it first came out. I'm not a big fan of it. It just works completely differently. And there was too many like thrombotic events. It can cause, it caused clots everywhere. We saw clots in the mesentery, saw clots DVT. So I'm not a fan. Vasopressin is usually second line for septic shock. Acts on the vasoreceptor, the V1 receptors, which are kind of all over. But it'll help. I think vasopressin is good in a GI bleed. Yeah, second line for sepsis. What else? I don't think I'm going to talk about dopamine. Dopamine, I can't even remember the last time I put some on dopamine. Honestly, if you need to get some heart rate, give them some isoprel, get a pacer. Yeah, I think that's kind of it, y'all. I think that's all I have to say about vasopressors. We are at 36 minutes. We have one person. Hello. Thank you for joining. We're about done with the makeup tutorial, which I know y'all have gotten a lot out of. Because I overplucked I don't know if it's because I overplucked my eyebrows. Oh, I forgot to do. See, this is what happens when I'm not paying attention. I do 2 phases to my mascara. I do like a primer, and then what the hell do I do with the primer? Here it is. I'll do a primer, and then I do the actual mascara. So that would look really weird if I went to work with like only one side of eyelashes showing up. Then again, it's nights. Nobody cares on nights. Anyways, my eyebrows are very thin, and thin eyebrows are not in right now. So I draw them in. I draw them back in. It's kind of a pain. My daughter Hannah got her eyebrows like not stained, but like tinted ones. It was kind of cool. I'm too scared to do it though. Like I know it wears off after a while, but like it's just a little bit too permanent for me. What if you get it on there and you look ridiculous, you know? And I go a shade lighter than what I actually am because my hair that I dye, because I'm gray, is a shade lighter than what I am. So, got to keep everything matched. Perfectly matched. Tonight is my second night and I'm tired already going in. I can only do 2 nights in a row. Everybody will say that does nights, they only want to do, like they don't want to flip-flop. I actually don't mind the flip-flop. As long as like I'll work a day and then I'll follow it with 2 nights and it'll be okay. But no more than 2 because I do not sleep during the day. Like I think I slept 3.5 hours a day. So that's it. 3.5 hours. It's not a lot. Okay. I think we have reached the end, my friends. Here it is. Finished product. Yeah. Leave me some comments. Let me know what you want me to talk about next. Thanks for joining all 3 or 4 of you who hopped on here periodically. Maybe we'll do this next week.